Good morning, everybody. Thank you for joining us on this August 7th, 2025. We're going to wait just a couple of more seconds to allow attendees to join the meeting, and we will begin momentarily. Callie, can you ensure that I'm spotlighted as well as ASL? Good morning and welcome. We are doing the Alzheimer's disease and related conditions advisory committee meeting this morning. Today is August 7th, 2025, and we will be conducting this meeting from 10 a.m. to 2 p.m. Thank you to everybody who's joining us today, committee members, guests, as well as public stakeholders and partners. My name is Jackie Tompkins. I serve as the Master Plan for Aging Project Director here at the California Department of Aging. And before we delve into today's agenda and content, I'm going to walk through some meeting logistics to support this session. This meeting is conducted in a hybrid format. I know we have some committee members and guests joining us in person at our California Department of Aging offices. And then we also have members and guests that are joining us via Zoom. So you can connect with us via Zoom, and then please know that the meeting resources, the slides, the recording, and a variety of meeting content will be posted to the Alzheimer's disease and related conditions advisory committee webpage following this session. Accessibility. Throughout today's session, we will have American Sign Language provided by our partners Rex and Bailey. If you would like to enable closed captioning during this meeting, there is a feature within Zoom that allows you to do this. To initiate closed captioning, click the CC icon on your Zoom toolbar. If for some reason the CC icon is not automatically available on your Zoom toolbar, please select More, and then there will be an option to select captions to enable the closed captioning feature within Zoom. In terms of our meeting operations today, the chat function in Zoom is enabled only for committee members, California Department of Aging, and other state staff and our invited guest. And during the course of the meeting, committee members and the state staff and invited guests are more than welcome and encouraged to share meeting-related resources and information. Although the chat is not enabled for the public, please know that any content that is shared in that chat will be available to public attendees. We will have a couple of public comment periods during today's meeting, and so please hold your comments until those designated public comment periods. Additional public comments and questions can be posted in Zoom using the question and answer feature. And then at any point, you're able to email us at engage@aging.ca.gov. Next slide. When we have our public comment period, we will take a moment to see if there are any in-person comments for those of you joining us at our CDA offices. So you'll want to raise your hand and let the designated staff member on site know that you want to make a public comment. If you are using Zoom and would like to do a verbal comment, please use the raise your hand feature of Zoom or press *9 on your dial pad, and then we will indicate that your line has been unmuted and you can make your public comment. Please share your name, your organization, or any other affiliation you have with your public comment. And as indicated earlier, we are happy to accept your written comments either in the Zoom question and answer feature or our Engage inbox. Important to note for this session that each public comment period or each public commenter will be have 2 minutes to share their verbal comments during this meeting. And with that, I would like to welcome our committee chair to walk us through today's agenda and begin today's content. Thank you again for joining us. Wynn? I'm sorry, Wynn, I think I need to unmute you or have you unmute yourself. We're not hearing you.
Okay, now try. Good morning, everyone. Can you hear me now?
Yep. Thank you. Yes.
Great. All right. Well, welcome to today's Alzheimer's disease and related conditions advisory committee. I wanted to begin by thanking each of you for being here, whether you're joining us in person or virtually, and for the commitment you bring to this very important work. So before we I'd like to take a moment to recognize and warmly welcome Assembly Member Pellerin, who joins us in her ex officio role as a member of the Alzheimer's disease and related conditions advisory committee. Thank you, Assembly Member Pellerin, for your partnership and for being with us today. Now I'd like to check for quorum. Do we have enough people? For committee members participating via Zoom, please turn on your cameras on as required by the Bagley-Keene Open Meeting Act. If you're experiencing issues, feel free to let us know in the chat. Have enough people. I'll go over the agenda really quick. So we have the Department of Aging update, assisted living spotlight, public comment. We'll have a break and then committee updates, Department of Public Health update, legislative update, and then public comment again. And then we will finalize our recommendations for our secretary, and then we will close around 2 o'clock. Since we have a quorum, I'll now take a roll call for committee members. Please respond when I call your name and indicate if you're joining in person or remotely. Carlos.
Here, in person.
All right, great. Assembly Member Gail Pellerin.
Rhiannon Mulligan on behalf of Assembly Member Pellerin, virtually.
Senator Jesse Arguen. Okay. Sally Bergman. Claire
Present.
Day. Virtually. Claire Day. Present in person. Dr. Thompson is not going to be here. Myra Garcia. Ken Raffio. Barbara McClendon.
Here, participating remotely.
Dr. Mobley.
Here remotely.
Dr. Kazi.
Here via Zoom.
Celine Regalia. I think she's not coming. Julie Solari.
Here remotely.
And Dr. Farias. All right. Well, thank you. Based on today's attendance, we do have a quorum. As a reminder, quorum for this committee is 7 members. Let's move to approve the minutes of our May meeting. I hope you had a chance to take a look. Are there any corrections or comments? And then from our virtual world, hearing none. None here. Okay. All right. Can I get a motion to approve the minutes?
So moved.
All right. Claire.
Second.
All in favor?
Aye. Aye.
Aye.
Aye.
Aye.
Well, thank you. The May minutes are approved. Don't know if Susan is here now. Okay, great. All right. Now we're moving to our Department of Aging updates. Our CDA Director, Susan Dumoris, is here to join us. Thank you so much for being here.
Thank you. I'm so happy to be here and to join all of you. Good morning, everyone in the room and joining virtually. I'd like to start out first by thanking Wynn and Carlos, our chair and vice chair, and all of the committee members for your laser focus on the most critical topics facing Californians living with Alzheimer's, dementia, and related conditions. Today is a great example. I'm really excited about our topic, focusing on assisted living, and I'm looking forward to hearing from our partner departments about their great work and uplifting that for all of you. It's also wonderful. Welcome to our new members. It's so just fantastic to have a direct connection now to the legislature as a result of the bill that passed last year, and welcome to the Assembly and Senate representatives. A couple notes from the Department of Aging. We achieved an important milestone since we last met. We submitted our Older Americans Act, we call it the OAA, state plan update to the Federal Administration for Community Living. This is something that is required of every state unit on aging in the country every 4 years. So ours was due July 1st. We got it in the day before. We're really proud of that. And it is now pending approval with ACL, the Federal Administration for Community Living. I want to thank all of you who attended our public hearings or offered comments. I know many members of this committee did contribute, and thank you for that. ACL is one of the federal agencies that has had a significant reduction in force. The department has seen its staff reduced by about half, and we no longer have a regional liaison. Formerly, that was Faye Gordon out of San Francisco. So there is no longer a regional administrator structure. They are in the process of being folded under the Federal Administration for Children and Families. And there's a lot of change happening there. So we're confident our plan will be approved by October 1st, which is required, the start of the next fiscal year. But just want to acknowledge this is an uncertain time. In light of that, I hope all of you saw the opportunity to listen to a webinar produced by the California Health and Human Services Agency, led by our secretary, Kim Johnson, and representation from the directors of the Department of Healthcare Services, Social Services, and Covered California, where we are seeing the most significant cuts and changes as a result of the Big Beautiful Bill. So if you've not seen that webinar, I would encourage you to take the time to look at that. It's a very fact-based accounting of what we can expect in California over the next several years as provisions from the Big Beautiful Bill play out. In our world, we have been most severely impacted by the reductions to the CalFresh program, CalFresh Healthy Living and Outreach programs, as well as senior employment. Another update, you may know that we have a vacancy in the state long-term care ombudsman role, formerly held by Blanca Castro. Currently, Eden Rosales is acting in that role and doing a fantastic job. Later this summer or fall, we expect an appointment by the governor. This is a governor's appointee position, but I just want to underscore that Eden is a long tenured employee of the state long-term care ombudsman program and is leading that team in Sacramento as well as the local ombudsman quite well. Because you're focusing today on residential care facilities for the elderly and assisted living, I wanted to report on a few highlights and data points from our long-term care ombudsman program. First, many of you in this room advocated for, and thank you for your advocacy because you were successful. There was a budget augmentation of $3 million for the state long-term care ombudsman program that will play out over the next 3 years. So thank you to the legislature and to the governor for approving that budget augmentation. Those dollars are sorely needed and will be put to good use. In the most recent report from the long-term care ombudsman program, they conducted 70,000 total facility visits in 2024. Of those, 7,798 are RCFEs, which will be the subject of today's conversation. RCFEs in California represent 206,000 beds, far more than nursing homes. And the Ombudsman program last year in 2024 received 11,499 complaints that generated out of RCFEs. It is consistent between RCFEs and skilled nursing. The primary complaint is around abuse, gross neglect, exploitation, which accounts for about 14% of all complaints. The second category of complaints would be care. Typically, that is symptoms that have gone unattended. That's around 7%. And then the third would be care planning. So I just wanted to make a link here. Ranjana, who's joining us and also staffs the Elder and Disability Justice Coordinating Council. This is another piece of our stakeholder work tied to the Master Plan for Aging. There's quite a bit of crossover between what we call the EDJCC, the Elder and Disability Justice Coordinating Council, and this group. And that's an area where I really encourage further partnership and collaboration to make sure that the needs and concerns of this committee are elevated to EDJCC. And if there's any sense that they're being lost with that group, which has a broad agenda, encourage you to focus on that topic at a future meeting. Last, I want to thank Wynn and Carlos. They are media stars and darlings. They took the time. They said yes when asked and took the time to be featured in an ABC television segment that we'll be showing you later in the agenda today. It has generated lots of interest and awareness, and it lifted up other partners in our network too. I want to thank Barbara McClendon, a member of this committee as well. She stepped in at a recent ABC town hall in Los Angeles. She was there as an invited guest, there to listen. And at the last minute, she stepped in to represent Alzheimer's and dementia. There were many, many questions from the group, from the audience, and she just did a superb job. Also, Dr. Anna Chodos from UCSF represented in both San Francisco and at the town hall with UCSF Fresno. So or we had a representative from UCSF Fresno, not Dr. Chodos, but thank you. Thank you for our network. It was so important to us that Alzheimer was a focus of all of those media events, and you all delivered. So thank you very much. Two last points about the Department of Aging. We are wrapping up our work around Senate Bill 1249. This was passed by the legislature and signed into law by the governor last September. And it is an extension of our California 2030 work, which is really the state's effort to strengthen and sustain the aging network, principally the 33 area agencies on aging. So we're concluding an extensive stakeholder engagement process with our 33 area agencies on aging. That'll wrap up next week, and we'll make those recommendations public at that time. All of the recordings are available on our website, and we'll make sure you have that link if you want to tune in to what we're doing about core programs and services, interstate funding formula, and the process for designating and de-designating AAAs and setting planning and service area boundaries. Last but not least, we are working diligently on a statewide consumer-facing website with an embedded aging resource directory that we intend to launch May 1st, 2026, as we kick off Older Americans Month and Older Californians Month. This will be a signature capstone project of the governor's master plan for aging, as we state our intention to improve navigation, information, and assistance for all older Californians, people with disabilities, and family caregivers. So you'll see more about that, and I'm happy to take any questions if there's time, or turn it over to Win. Turn it back over to Win.
Right. Yeah. Okay. Well, thank you so much, Susan. And move on to our next agenda. Is to bring
Win, we cannot really hear you very well. Also, I see that Dr. Mobley has his hand raised.
Yeah, hi, this is for Susan. Again, Susan, how many complaints were received, and how many beds are we talking about that would have been under the kind of umbrella of those complaints?
Thank you, Dr. Mobley, for that question. I'll share in the link the most recent report that the state long-term care ombudsman produced so that you can all have access to that. But there are 7,798 RCFEs in the state of California, and our colleagues at DSS can correct me if that's a mistake. That represents 206,000 beds. That's where we're seeing the most growth. We're actually seeing some shrinkage in the SNF, the number of skilled nursing facilities and the number of SNF beds. In 2024, the Ombudsman program received 11,499 complaints that were generated in the RCFE setting. That's about half the number that generate from nursing facilities, where there are far fewer. So percentage-wise, fewer complaints come from RCFEs, if that answers your question. And I'll put the full report in the chat for all of you.
okay. Press unmute.
Okay.
Can you hear me now?
Maybe
What about now? Awesome.
Yeah.
Okay. We're having some tech issues here, but I think we're good to go now. Thank you, Susan, again for that update. So now we are pleased to bring a focused spotlight on assisted living, specifically regarding dementia care in residential care facilities for the elderly, or RCFE. As California's population ages, it's critical that residential care settings are equipped with policies and practices that meet the complex needs of residents living with dementia. To support this conversation, we are joined by Thea Perino and Stacy Barlow from the Community Care Licensing Division of the California Department of Social Services. Stacy, are you ready? Great. Or Thea first. Thank you.
Hi, yes, I am ready. Thank you so much. And it's a pleasure to be here today on behalf of the California Department of Social Services. My name is Thea Perino, and I serve as the Assistant Branch Chief of the Policy Training and Quality Improvement Branch. And I'm joined by my colleague, Stacy Barlow, who is the Assistant Program Administrator with the Adult and Senior Care Program. And we're also joined by Victoria Rodriguez Hinojosa, Chief of the Policy Development Bureau, who will be here to help us answer questions following the presentation. So I want to start out by saying that we're honored to participate in today's meeting with the Alzheimer's Disease and Related Conditions Advisory Committee, and we're really looking forward to our discussion. And today we will be discussing dementia care in RCFEs and miscellaneous regulation package, which has been in effect since January of 2025. We're here to provide an overview of the substantive changes in the regulations, implementation measures, and also to answer any questions that you may have. While we will be providing a high-level summary of the changes, we invite you to review the full approved package at your convenience. Reviewing the complete text of the package can help support a shared understanding of these updates, and we're available to answer any questions or discuss specific areas of interest you may have. And I will pass it over to Stacy.
Thank you, Thea. This package significantly reforms how dementia care and other cognitive diagnoses are managed in our RCFEs across the state. The updated regulations are the result of a multi-year collaboration with external partners. The previous regulations, last updated in 2004, were based on outdated understanding of dementia care and written at a time when fewer residents with dementia lived in RCFEs. These regulations focused on diagnosis rather than individual needs. Given advancements in care and evolving resident needs, a comprehensive update was necessary. The new regulations are guided by 5 key principles established by a dementia care work group. Promote aging in place with fewer restrictions. Recognize the broad range of cognitive conditions in RCFEs. Address resident behaviors regardless of diagnosis. Emphasize person-centered care, and ensure a balanced approach that supports both residents and providers. And I will turn it back over to Thea to review the substantive changes.
And so I'm just going to give you a very high-level overview of some of the highlights of the new regulations. So as Stacy mentioned, these address resident behaviors regardless of the diagnosis. They focus on person-centered care in regard to access to items and response to behavioral expressions based on individual needs of residents. For example, all residents, regardless of their diagnosis, may or may not have access to specific items, such as cleaning solutions or sharp objects. And it's really based on their individual need and the pre-admission appraisal and the reappraisal. And definitions that support the regulations have also been modernized to align with terms used by experts in dementia care, and they use neutral, objective language to describe a condition rather than something to imply a potential inability or a negative effect of the condition. So it's really trying to get rid of any stigmas. And then finally, updating the reappraisal section to require that if a licensee observes or is made aware of behavioral expressions, they must describe that expression, the events that occurred right before that happening, and any interventions that may minimize the risk of health and safety for that resident and residents in the facility. And this also must all be documented in the resident's reappraisal. And I'll turn it back to Stacy.
Thank you, Thea. In addition to the key highlights we've discussed, the updated regulations also include miscellaneous changes, such as medical assessments. These assessments must now be signed by a licensed medical professional, in other words, a physician or a nurse practitioner, and include details on behavioral expressions. Overall, there have been quite a few substantial changes to the regulations with the goal of better supporting our residents with dementia and other cognitive diagnoses residing in RCFEs across the state. And I will turn it back over to Thea.
And so now that we've reviewed the key regulatory changes, I want to shift our focus to what steps we've taken to implement these new regulations effectively. So first, we have a dementia care resources hub, And I'm going to ask the team to share that in the chat. Thank you so much, Victoria. We encourage everyone to bookmark this resource and take a look at all of what is available on this website. We update it frequently, and so you'll be able to learn the implementation measures as we continue to implement this package. What this resource hub does is it houses everything related to the implementations of this package. And I'm going to walk us through just a little bit of what is on this resource hub. So first, we have developed a flyer that highlights key information about these regulations. And also this flyer includes a link to the resource hub. And I believe Victoria may be putting that flyer in the chat. This flyer provides tools and guidance to support implementation. It's intended for broad dissemination. So our licensing program analysts have distributed this at their facilities, at their site visits, and we are encouraging licensees to post this in their facilities. And partners like yourselves are also encouraged to share this with your networks. So thank you so much, Victoria, if you dropped that link in the chat. The next one is we have done a provider information call. On December 5th of 2024, our adult and senior care program hosted a live informational webinar for our licensees, administrators, and training vendors. This webinar provided an overview of all of our substantive changes that address dementia care and other aspects of providing care to residents in our RCFEs. And if you would like to check out this recording, it's available in our Dementia Care Resources Hub for you to view. The next one is our provider information notices. This is the main way that we share written information with our many providers. And so we provided information about the summary of these changes for all of our residents and our licensees so they could better understand and implement these changes. And next, we created a more detailed guide for navigating the substantive changes. So this guide, which also on the Resources Hub, is a step-by-step walkthrough. So what did the regulation used to say? What is it saying now? It's really that step-by-step so that people can understand what has changed. And also what the benefits are of this package is also noted in there. And then our medical assessment form for our CFEs. This is a courtesy form that we updated in April of this year. This is a comprehensive template that helps our prospective residents, and our licensees obtain the needed medical assessment that meets the requirements outlined in these regulations. So for note, that is our LIC 602A form. That's our updated medical assessment. And finally, our frequently asked questions page, a series of questions that have come up over the implementation period. We are still continuing to update this FAQs. In fact, this week, we just released a 2.0 version of these FAQs because we are always looking at quality control and continuous improvement. And these were also shared with our field and our licensees. And then finally, additionally, as a department, we are developing plans to monitor compliance and non-compliance with these new regulations. And this will happen during our annual inspections. We are currently working with our data teams to discuss the timing of when we need to retrieve this information, and we'll provide updates whenever possible. The compliance information that we retrieve will also help our department inform whatever additional resources may be needed to effectively implement these regulations. And so as part of an ongoing effort, we want to continue to collaborate with our external partners like all of you as we gather feedback on how these regulations are being implemented in the field. And I will pass it over to Stacy.
Thank you for all that, Thea. And thank you for the opportunity to speak with all of you today. As we've gone over, the updated dementia care regulations and RCFEs represent a critical step forward in ensuring safer, more compassionate, and a person-centered care for residents living with Alzheimer's and those with behavioral expressions. Together, by staying informed and engaged, we can continue to advocate for quality improvements that truly support dignity and well-being at every stage of life. We encourage you to share the resources we've highlighted today with those in your network to help broaden awareness and support in implementation. We appreciate your partnership in this vital work, and we can open it up for any questions the group may have. Thank you. I see a question from Dr. Mobley.
Yeah, thank you very much. Really an important effort. I'm looking at the numbers that you stated. Were stated earlier by Susan. Complaints about abuse, neglect, and exploitation being relatively common. I'm wondering, and I've spoken, I think, before about this with folks here. I wonder to what extent caregivers have been given tools to allow them to more effectively empathize with those they care for. I'm wondering whether there's any emphasis on really the more personal, social kinds of interactions that would be very important to mitigate abuse and neglect and exploitation. And I just think that's a very important concept, and it may be that caregivers, non-family caregivers, I would emphasize, maybe they don't really know the tools that could help them be more in the moment and be more empathic and compassionate to those they're caring for. Any comments would be very appreciated.
Hi, Dr. Mobley. I'm Victoria Hinojosa with the Policy Development Bureau. Yeah, the caregivers that you're speaking of in our CFEs, they do go through a pretty robust training program as required by the statute. In addition to and I believe the training elements does cover those types of items that you're speaking about. Specific to this package that we've gone through or that we've recently updated, we hosted a public provider informational call that went over the new regulations. And I know also, I'll let maybe Stacy speak to this a little bit more, but I think LPAs are also our licensing program analysts, the individuals that are out inspecting the field, inspecting these facilities. They're also hands-on with the licensee and providing them technical assistance. And then one more thing I'll note is that we do at the Department of Social Services have a technical support unit that is also really hands-on with licensees, that if there are any areas that a specific licensee may need additional support and assistance, especially abuse and neglect. Yeah, those licensees are given a little more assistance. And Stacy, I don't know if you have anything else to add regarding that.
I'm just thinking we should measure that, right? I mean, we should measure the efficacy of that intervention or that training, because what I'm hearing is that whatever good work we're doing, there's a significant number of complaints about abuse and neglect, and I would argue that we're not doing what we need to do if we're having complaints at that level around those very interpersonal kinds of interactions. And so I'm wondering, are we doing enough? And have we measured the efficacy of what we're doing along with that training?
Yeah, to respond, thank you for your comments to that. To respond to the reviewing of the efficacy of the training, I don't know that, Stacy, if you have a specific response to that, of a look back of a specific measurement, no. But we do, go out on complaint visits, we go out on annual inspections, and we go out on, just like I said, the technical support. But as far as measuring the efficacy of, for example, a provider informational call, I don't think that is something that is currently done, but I will take that back.
Can you hear me?
Okay. Just want to make sure. Thank you so much for that comment. I'm glad that there is caregiver training. When is that required? Is it as soon as the caregiver is employed? Is there one maybe every, once a year requirement to attend? I am a psychiatrist and a geriatrician that see a lot of patients with dementia, a lot of them living in RCFE. And I would get a fax from an RCFE med tech saying, this is the behavior order Seroquel checkbox. I'm hoping that I would actually get more information like what you are all recommending in the future, and just kind of reinforcing that on a regular basis so that I could get more information rather than just asking for a medication right away.
Yeah, so as far as the training goes, there's
You're muted.
initial
Sorry.
training. Sorry, I was getting a little feedback. There's initial training required and then subsequent ongoing training. And there's also hands-on training. I can, obviously I'm not very good with the chat. Thanks, Tanya, for backing me up on that flyer. I can drop in the chat. The team has also developed a really helpful, we like to develop guides over here at CDSS. We developed a guide to training in RCFEs, and it covers the breadth of what is required, which is pretty extensive, enough to have a guide developed. So it's not just for our caregivers, although it's of an RCFE reform in 2015 that came out of that. There's an extensive training there. Also, our administrators go through an extensive training. In addition to caregiving, there's first aid, CPR. So yeah, I can hopefully put it in the chat, that guide to a guide to navigating training in RCFEs. And that will go through all the specifics that you're looking for. So I can't put it off the top of my head, but I know it's initial, then there is ongoing, and there is an element of hands-on. Additional to that, there is also a dementia, that's what the statute refers to it as, a dementia care add-on training for that. Yeah, that's required. That has now flatlined it for all of our CFEs. And this one that Jackie Thompson put in the chat, this is a resource for the dementia care changes, but we also have one for training, broad training that's required in our CFEs.
Thank you for that, Victoria. And I would just like to add that, those are things that the department does want to know about. If you're just getting something saying put them on medication, we would want to know. We want to look into that. We want to provide that technical assistance to those facilities. And those are things that we may not know is happening until you maybe call in a complaint. We don't want to receive all the complaints, but we do want to know. We want to know what's happening out there, because we can't help change the industry if we don't know and don't have the opportunity to go out and provide that technical support to our facilities out there.
Right. So just a clarification, send a report to CDSS directly or to the local ombudsman?
To CDSS directly, please. And you can sorry. You can file that with you can file that with our intake bureau, our complaint intake bureau.
Okay.
So we do have, just to reiterate that, we do, and we absolutely want to know about complaints, and we do have that, as Stacy mentioned, the centralized complaint bureau, which is intake for all of these complaints statewide. It ensures it's routed and followed up on. There's many ways to submit a complaint. We have a portal that's all available online. You can call 1-800 let us know. Fax, email. So yeah, there's many ways, and we do encourage that. And if you want to dual report to the ombudsman as well, that's okay, but we encourage to be sent to us as well.
Thank you. Looks like Claire has a question or a feedback.
Turn your volume on.
Apologies. Can everybody hear me?
Okay, we're having some tech issues here, so I apologize. So just thinking back to the questions that Dr. Mobley asked, sort of in line, thinking of the workforce the way I think many of us on this committee know and understand the workforce. When you're talking about training, are there opportunities for staff to learn in their preferred or first language? Because we know that many of the staff that are providing this care, especially those around behavioral expressions, English is probably not their first language. Are there ways to ensure that the training is provided so that they actually understand in their language?
I'll let you, Stacy, I'll jump in here, but I don't know what you're seeing out in the field. There's no preclusion to that. It's incumbent upon the licensee to provide the training. The department does not provide the training. We just ensure that the training has been completed. The statute doesn't speak to any language, any specific language to be given in, and therefore it doesn't preclude it. So, yeah, that's not a preclusion. So, hopefully licensees would be doing that, but I'm not sure, Stacy, if you can chime in on that, if you're seeing anything that yeah, they would be providing it in their language or not.
Thanks, Victoria. I don't, there's no data that I could speak to on that, or, the observation though would be that most of the time, the facilities and if you have a facility of a certain language, everyone is speaking that language as far as the caregivers. But as Victoria stated, there's nothing in statute or regulations that requires the training in different languages. So that's definitely something that we can take a look at.
Anyone else have any questions about our updated dementia care regulations or anything else?
There's no other questions. I'd like to thank Thea, Stacy, and Victoria for your information and insights. Continuing the spotlight on assisted living, we now shift to the assisted living waiver, a critical Medi-Cal program that enables older adults and people with disabilities to receive care in community-based settings. This update will also touch on broader home community-based services, integration efforts, including enhanced care management and community support, key strategies under the state's Cal-AIM initiatives. We're joined by Xiomara Watkins-Brisci from the Department of Health Care Services, who will share important programs developments and what this means for individuals living with Alzheimer's and other dementias.
Good morning. My name is Xiomara Watkins-Bresci with the Department of Healthcare Services, and currently I'm the Acting Division Chief for Integrated Systems of Care Division. Our division oversees all 1915C waivers in the state, and we administer some directly. Additionally, we are also responsible for oversight of the California Children's Services Program and other specialty programs that are for children. My regular job is the Home and Community-Based Services Operations Branch Chief. My team is directly responsible for overseeing the operations of the waivers that we administer directly at Department of Healthcare Services, as well as for the California Community Transitions Program. Okay, so I'll go ahead and get started. So like as was explained, today I'm just going to talk about the assisted living waiver and provide like an update on current status of our wait list, discuss our wait list a little bit, and discuss community supports and the future of what DHCS's plans are for the future of this waiver. The goal of ALW is to facilitate a safe transition from an institutional setting, and it also to offer individuals that are already in the community the option of using ALW to receive all of their services in a residential care facility for the elderly, adult residential care facility, or public subsidized housing. Care coordination agencies across the state are responsible for assisting members with the application and enrollment activities that, as well as post-enrollment and during, while they are still residing in the facilities. Additionally, they are also responsible for coordinating any moves that are necessary. And here, this first slide is just displays the current eligibility criteria for the waiver. One important thing that I will note is that the waiver participants are responsible for making their own room and board payments. That's sometimes something that's not understood as part of the waiver. The waiver does not pay for room and board. So we cannot, usually members are using other income like Social Security to pay for that room and board. Next slide, please. Okay, so participating counties. This is just a list of the participating counties. The most recently added county was San Francisco, and that was in 2017. Since then, we have not added any other counties to this waiver. Next slide. So here's just a display of the current assisted living waiver reimbursement rates. This is the rate that a facility will make for an individual that is residing in their facility and receiving ALW. The tier levels of individuals are determined using a ALW assessment tool, and they go through questions about functional capacity, activities of daily living, cognitive capacity, and that will develop a score that determines their tier level. Tier 5 is only for individuals that have had a traumatic brain injury diagnosis and meet that level of care required. These rates are periodically updated along with the state minimum wage. Additionally, we have transitional care coordination and monthly care coordination rates that the CCAs receive for providing that care coordination and transitional services. Next slide. Here's the current statistics of our waiver. Our current waiver term ends on February 28th, 2029. Current waiver capacity is 16,344. And you'll see right there what our current enrollment and our ALW waitlist as of July 1st, 2025. Next slide. So on September 24, 2024, DHCS halted the direct submission of new ALW applications because we were reaching waiver capacity. We were getting pretty close. In fact, we did reach waiver capacity, and we ended up having to stop all applications for a few months while we determined how we were going to fix that issue. And we fixed it by submitting a waiver amendment to make the increase authorized for waiver year 2 available in waiver year 1. And subsequently, we submitted another waiver amendment to increase waiver slots each year, concurrent with each waiver year term. In addition, we implemented the ALW policy letter describing the waitlist management. Next slide, please. So available waiver slots based on our policy letter and in our waiver, we've described how waiver slots are assigned. We release them every month. And individuals residing in institutional settings and individuals that have imminent need as documented in an APS referral, or individuals that have imminent need as documented in the long-term care ombudsman referral receive priority enrollment. Other applicants are assigned on a first come, first served basis. The next, right here. The next slide talks about what our waitlist numbers look like. So we have, and this of course is approximate for the wait time. This is like our best estimate of how long it takes for individuals to wait. This varies a lot because our wait list changes a lot. So we try to kind of give you a gauge because we get this question a lot. So applicants that meet the reserve capacity criteria, which is the institutional transitions, APS, and long-term care, we release those slots at a certain ratio. So 50% of the slots we release are for individuals in that are institutional transitions, and then 50% go to are split up between APS and long-term care for those reserve capacity slots. If there are no individuals on one of these lists, then we can then release slots to individuals that are on the regular wait list. Question?
You can hear me?
Yes, I can now.
Okay, great. Thank you. Thanks for that information. So can you go back to the prior slide? I just had a question about the slot. So this means the slot is over, it's almost 13,000. Is that correct? Or the wait list is 13,000? I didn't know if
13,000, yes. Mhm. Yes. It's a very, that is our largest wait list for all of our waivers, and it's always been pretty big, so unfortunately. Mhm. Another question?
Yeah, could I ask you to go back? I don't know if it's one slide or two. I may have missed it. Yeah, did you mention the status of this March 2025 waiver submission?
Yes, yes. It got approved, and so currently we are receiving regular slot increases every year by 1,800 slots, but we are still in waitlist status because we want to make sure that we monitor the enrollment so that we don't end up in a situation like we did in 2024 where we actually had to halt enrollment for a few months.
Okay, thank you.
So this slide just provides you some important links so that you can see how to contact us, how to contact the care coordination agency, and then of course the direct email address to my team that oversees the operations for the waiver. To reserve a spot, like we still encourage everyone to reserve a spot on the wait list. So it's, very highly encouraged, even though it seems like it's a very daunting wait list. We highly encourage to reserve a spot. You must contact the care coordination agency in the area, and then they will submit a wait list request to DHCS, and we will make sure that the person is on the wait list and in the appropriate placement. Okay, so next slide. So I'll go over Cal Lane Community Supports. Community supports are services that help address members' health-related and social needs, and they're also intended to avoid higher, costlier levels of care. Some of these services that are available through community supports, which are available through our Medi-Cal managed care plans, they are optional benefits, but a lot of these services mirror the services that are allowable in our waivers. Specifically, the assisted living facility transitions community support functions very similarly to the ALW in that it provides assistance transferring a member from an assisted living facility and as well for the ongoing care while they're in the facility. Additionally, assisted living facility transitions provides for transitioning assistance with transitioning somebody from their home to an assisted living facility if that's medically necessary. So last month we released a policy. Well, actually, this was probably more than a few months ago that we released a policy guidance for the community supports, new policy guidance. And in this policy guidance, we clarified that the benefit could be used to cover continuous costs for ongoing care at the facility for undetermined length of time. Previously, many managed care plans were under the impression that the benefit was only transitional and that it could only be used as a bridge to ALW. So we made that clarification in this new policy guide. Another thing that DHCS has been encouraging is that effective May 2025, we've been encouraging managed care plans to utilize this benefit to also assist members that are currently on the ALW waitlist. And to facilitate this, we've started sending the managed care plans monthly lists of their members who are also on ALW waitlist with the intent of them going out to facilitate that delivery of the assisted living transition service to those members that need that service. Next slide, please. And just wanted to point out that we do have a search tool on the DHCS website to determine which managed care plans offer the community supports. And the link is here. And if a member is ever having trouble connecting with the managed care plan or you're not feeling like they're getting the support they need, you may also contact our managed care and mental health ombudsman office to get assistance for that member. And again, I'm providing the email address for our Cal Lane ECM community supports team that answer any specific questions that you may have following this. Next slide, please. Okay. So as noted, ALW is part of our broader home and community-based services programs. And DHCS has begun an initiative to support our transition to a statewide, fully integrated managed long-term care services support system. We've commissioned a gap analysis and a multi-year roadmap in pursuit of this effort. We've completed the first component and issued our statewide gap analysis report on February 14th, 2025. And based on the results of this report, as well as feedback from a broad array of stakeholders and advocates, we are in the process of developing a multi-year roadmap. Our multi-year roadmap will outline a strategy for integrating select home and community-based services, including ALW, into managed care, while continuing to support services through fee-for-service where appropriate. Critically, this effort does consider LTSS needs across the state and opportunities to scale home and community-based services providers' capacity in a sustainable way. One of our primary goals with this effort is to expand overall access to home and community-based services, including assisted living waiver services, by making them available statewide and increasing our waiver capacity. DHCS is still establishing what the timeline for the integration will look like, but we do not expect that it will occur any earlier than January 2028. And in the meantime, we will continue to renew and continue to operate the ALW. So we will not stop. We will continue to operate the ALW goingly. So next slide, please. Okay, so recently we also kicked off a work group of 23 members in April to gather feedback on design decisions and implementation considerations related to the integration of Medi-Cal home and community-based services programs. Work group members represent a variety of organizations, interests, and experiences with the waivers proposed for integration, including individuals with lived experience, receiving services from Medi-Cal waivers, from all of our Medi-Cal waivers, caregivers, managed care plans and managed care plan associations, providers, provider associations, and advocacy organizations. Additionally, we've also included our sister departments, Department of Aging and the Department of Public Health. The home and community-based services integration workgroup meetings are closed to the public because we want to allow for that candid discussion, but we are posting materials from these meetings on our website. Agency leadership will use the conversations and recommendations in both of this work group as well as existing forums like this one to inform thinking and next steps for our integration. And we also will use any feedback that we receive to inform the multi-year roadmap and the concept paper that will outline the plans and steps for this transition. Next slide, please. Okay, so I did want to share a few updates on the topics related to integration that we are currently discussing with the work group. First, we have been looking at federal authorities that are available to provide home and community-based services within the managed care delivery system. DHCS has decided that we will move forward with using a Section 1915C home and community-based services waiver alongside the state's existing 1915B managed care waiver. This approach is common in many other states. And the four programs that we will be integrating into managed care currently are already structured as 1915C waivers. So we just want to note that DHCS is still continuing to plan for this integration and things are still subject to change pending on state budget and policy considerations, and as well as any changes that happen moving forward. But second, we have a goal of expanding home and community-based services with integration, and we're currently modeling out certain options for how we will do that. The first major option that we're talking about is what we're calling a lift and shift approach, which would involve essentially like lifting our four existing home and community-based services waivers. And those are, I'm just going to list those out real quick. It's the assisted living waiver, the multi-purpose senior services program, the Medi-Cal waiver program, and the home and community-based alternatives waiver. So those are the four waivers that we're considering to lift and shift into the managed care, which means that we will concurrently operate the waivers as they are operated now. Other than that, we're changing the managed care delivery system instead of a fee-for-service. The next option that we're considering is, it's a much bigger option, but it's basically we're going to create new waiver, a couple new waivers that we're going to, right now we're calling the de novo waiver. And this will include a combination of the existing services across all of our waivers. And it can serve as a blank slate for us so that we can really create something that will work for all of our members and the community. So in this section, in the second option, we're considering consolidating the current waivers into two 1915C de novo waivers. And they will target two different populations. One will be for youth, children under the age of 21, and the other one will be for adults over the age of 21. Each de novo waiver will be delivered under the Medi-Cal Managed Care Delivery System. And then finally, we are also reviewing options from the work group for several other aspects of the integration, including populations that are being served by the existing waivers, to make sure that we continue to meet the needs of Medi-Cal members and that the service package that we're offering doesn't, minimize anything, and it also minimizes duplication of existing managed care services, but that we don't lose any of the existing supports that people are currently receiving. And of course, we are making sure that throughout this entire discussion, we are thinking about how we're going to offer member supports during the transition period. Okay, so next slide, please. Okay, so here is just a timeline, a quick little timeline that kind of describes what our next steps are. Throughout this fall into next year, we will be working to develop a concept paper for CMS that outlines our proposed transition of these waivers into managed care. And we're incorporating the learnings from these discussions and decisions that are being made at the HCS. As part of this concept paper, we will be convening regular and ad hoc internal meetings with other divisions in our department, as well as staff from sister agencies, to strategize and consider all of the options that are available for home and community-based services integration. And this will be happening throughout the summer and the fall. The home and community-based services integration planning work group will review the concept paper in winter of 2025, and we will be refining and finalizing specific transition and feedback for HCBS programs into managed care so that we will create this multi-year roadmap and based on that feedback that we're receiving from the concept paper. So as I noted before, this timeline is subject to change. It really depends on policy and budget decisions, as well as anything that we've, determined through the work group. But the waiver transition will definitely not be occurring any earlier than 2028. And that's all I have for today. Any questions?
If no one has any questions, we can move on. Oh, we do have a question from Barbara.
Yeah, you guys are echoing in the meeting room. Just a quick question, Xiomara, for the assisted living facility transitions, community supports, do you track how many people with a cognitive impairment are taking advantage of that? Just curious.
We do track utilization in the assisted living transitions program. I'm not certain that we track down to that level, but I can take that back. My assumption is that we wouldn't. I don't think we'd have that data available, but I can definitely ask.
Yeah, I think you probably don't, but it is over many years. It's been a point of conversation when we look at assisted living waivers and the settings where people can receive care and how people with cognitive impairment, like where they are in that whole space. Because I think I am certainly operating from an understanding that it's very difficult for people who are living already in a skilled nursing facility, living with a cognitive impairment, to transition to a lower level of care in any way, would be that assisted living or back to the community. So if it'd be interesting to see if you did gather that information, whether that would support that understanding. Thank you. And also just, gosh, I do hope at some point we are able to integrate this into managed care, because then it would be available to everyone across the state, which would just be incredible. And hopefully then we don't have this horrible waitlist situation. So I know it's hard and it's a bit of a long road, but I'm appreciative that DHCS is walking down it.
Thank you. Thank you, Barbara. And I wholeheartedly agree with you on the issue about the individuals that have cognitive impairments and the difficulties they have with being able to transition to the community. We experience that all the time in our current operations of the assisted living waiver. Once, especially in situations when individuals were okay, essentially when they were enrolled, like they were able to make their own decisions, and then throughout their enrollment, they become cognitively impaired. And then we get stuck in this area of like, well, what happens if, it's okay if nothing happens to the facility, but then if there's a problem, then that's where we really have struggles. So that's definitely something that, my team and I look at every day, and we think of like ways that we can kind of mitigate, negative impacts to individuals that don't have like anything, that aren't able to make those kinds of decisions on their own, but it is a difficult road. Mm-hmm. And of course, I hope that we don't have a wait list someday, because that would be amazing.
Anybody else have a question? I think that's it.
Any other comments, maybe? Can you hear us?
Yeah.
Just making sure. Well, thank you so much, Amara, for sharing this update and all the efforts being made to help our Californians to be able to get such service. Are we going on public comments then? All right. Transition to Jackie. Jackie?
Thank you.
Hi, everyone. Callie, if you're able to spotlight me before we get started. Wonderful. Thank you. So we are entering our first public comment period of the meeting. I think we also need, sorry, before we begin public comment, there's Rex for ASL. Is that correct? So let's begin our first public comment period of the meeting. For those of you joining us in person in the office, you are more than welcome to provide some in-person comments. Again, just please raise your hand or let the designated staff member on site know that you want to make a public comment. If you are joining us virtually and would like to make a public comment via Zoom, please use the raise your hand feature of Zoom and your line will be unmuted. Again, you are always welcome to send us written comments to our email inbox at engage, ENGAGE, at aging.ca.gov. And I also respectfully remind you that we will permit 2 minutes for each public commenter at this time. So I'm going to do a quick check for my colleagues that are in person joining the meeting to see if there's anybody in the room who would like to make a public comment.
The room.
None from the room, Jackie.
And in terms of those joining us virtually at this time, I am not seeing any of our virtual public attendees with their hands raised, but we can give it a moment or two before we transition to the next segment. I do see one of our in-person attendees, our panelist, Dr. Mobley. Would you like to provide an
thank you.
additional comment?
Well, I've looked now at the training objectives for assisted living, and I'm sure that they meet the standard of kind of the technical elements of caring for an elderly person. But when I look at it, I don't see there sort of a means by which to increase caregivers' ability to read the emotions, read the feelings, read the concerns that of the people they're caring for. Now, I'm sure that they're quite natively good at that, but a program that would support their ability to detect emotional changes in those they care for and to learn how to listen to them and really learn how to advocate for them, I think would be very helpful. So whereas the training activities seem completely reasonable, I'm wondering if they could be augmented by additional training activities that would allow them to more effectively hear what the person cared for is feeling and how they might more effectively respond to their concerns. So that's one comment. And I bring it up because if I'm understanding it, as many as 900 complaints were registered about abuse and neglect. And it seems to me whatever the training is undergoing, there should be an augmentation to reduce that number considerably. So that's point two. Point three is, are we able to evaluate the efficacy of training? It seems to me that there ought to be measures in place to really measure that. And I don't see in the guidelines that is done. I really believe that some level of inquiry around skills learned and skills maintained would be useful.
Thank you for sharing your comments with the committee members and those joining us from the public. Again, we're doing our public comment period. I do not see any hands raised. So I think from there, there will be an additional public comment period later on today's agenda. I think from here, I will transition it to the team who will show the Aging in California video that our director, Susan DeMorris, spoke to earlier today.
I think one of the perfect things to think about as we're going from middle age to older is brain health. We all have gotten the message about heart health, but really we should have been bringing brain health along the whole time. And I think now that we're seeing the aging population and some of the effects of not focusing on brain health as much, it's dawning on us now that we really need to bring that earlier and make it a lifespan issue.
The greatest risk factor for Alzheimer's and dementia is age. And as our population in California and across the nation ages, the rates of Alzheimer's and dementia are increasing.
Dementia is the major chronic conditions, the only major chronic condition that does not have any effective treatment and the significant source of disability in later life.
Here in California, we're closely watching the 85 plus population. That's actually the fastest growing demographic in our state, and that's where we see the highest incidence of Alzheimer's and dementia.
How you feeling, Papa? Good. 2015, we received a phone call from my dad's dentist, and they said that they had concerns about my dad's health because they were observing him missing appointments, getting lost, and some other symptoms. How long have you been playing Chinese checkers?
When I was a little kid.
The doctor, primary care physician, pretty much just said he has mild cognitive impairment and prescribed him some medications. to slow down the progression. But it was going to evolve.
What do you think about that? I did a good job.
We were a multi-generational family. My grandmother lived with us. My parents cared for her before she passed. It was part of the fabric of our family. So it seemed like the right thing to do. Come home and take care of Dad.
Caregivers are the most important resource an older adults, especially folks with dementia, have.
I was going through frustrations, not understanding my dad. And when it came down to really being educated, I was finding that I was talking to two different people, talking to my dad and talking to dementia.
Dementia is an umbrella term that we use. That means a person's cognitive ability, and that means their thinking skills, whether it's memory, being able to express themselves, reasoning, is now affecting their ability to function in their daily lives. So it's a change in both cognition and function.
There's stigma around dementia that all of a sudden you will, become nonverbal, etc. It has a wide range of expression. We know that supporting patients and having them, be able to be in home and community really does help.
We actually know a lot about what we can do for brain health. The things that we can do, particularly in middle age, believe it or not, one of the most important things we can do is focus on our hearing. It's also been shown to be a really, really strong risk factor if we have untreated hearing loss. The other ones are things like depression, social isolation, addressing the things that we all think of, again, with heart health. So diabetes, hypertension, cholesterol. So being mindful of medications that have cognitive side effects.
As I get older, I like to do a lot of things that I didn't do before. And now I'm free and can do whatever,
One thing a lot of people notice, for example, is mild word finding difficulty. Like they can't quite find the words, or they can't recall information quite as quickly, or they can't multitask quite as well as before. Those are all normal, but now you're forgetting the name of a nephew who you see all the time. These are signs where it may be getting more into the severe territory or a more significant symptom.
There was a point where I was so frustrated and despair, I ended up calling the Alzheimer's Association's 1-800 number. And the intention was to get into a workshop. They suggested a caregiver support group.
It's important to know what resources are available. And I think most importantly, what I tell caregivers is to really learn how to take care of themselves.
Dementia Care Aware is really an amazing program and project. It flows from the Master Plan for Aging and recommendations that came from the Governor's Task Force on Alzheimer's Disease Prevention and Preparedness. And essentially, it is a program, a series of trainings to help primary care physicians detect and understand dementia in their patients.
It was really going to close a gap in dementia screening access that existed for their members, the people who get Medi-Cal. And when they created it, they said, we need something that not only addresses the needs of our members, which are incredibly diverse, but trains healthcare providers on how to deliver this screening so that our patients, our members, get what they need. They put brain health and caring for people with dementia as an essential component of how we're going to help people get older. One way it's clear that California has been really forward-thinking is in making dementia screening a completely accessible benefit for all older Californians. Definitely not all states have that. And it's just been shown that if we find it earlier, it slows down. People can live incredibly full lives with dementia, and their caregivers can feel really supported, but we have to do it right. We have to identify that this is what's going on and support people.
Alzheimer's is really confusing. There's a lot of misconceptions, and it can be self-defeating. But the reality is, being here, being able to hold his hand, give him a hug, that boost of energy, that transference of currency that evolves every day. And I give him the courage to keep on going.
Every day, there are over 4 million caregivers across California who devote their time and love to support.
So we're gonna go ahead and take our 30-minute break. Can you hear us, by the way? Now have to check that all the time.
Can everybody hear?
Yeah, because there's silence. Welcome back, everyone. I hope everybody had a good lunch. Can you hear me?
Yes, we can hear you.
Yes.
Yeah. I learned.
When can you hold 1 second so we can spotlight ASL, please?
Oh, sure.
Thank you.
They are the backbone of our long-term care system, and there are many resources available to support them.
Are we ready now? Okay. All right, so we are now on our committee update. CDA received a strong response to the recent call for applications to serve on the Alzheimer's disease and related conditions advisory committee. There were a total of 53 applications were submitted for up to 5 available seats. And CDA is currently reviewing all applications in partnership with a review panel and proceeding with the interview process. Final selections will be made in alignment with the committee's bylaws with a focus on ensuring a diverse and representative membership. We're grateful to all applicants for their interests in supporting California's work on Alzheimer's and related conditions. Is Dr. Farias here? Let's see.
I do not see her yet, no.
We can pass it over to Claire that can provide that. Okay. Claire is here with us. She will provide us an overview of the U.S. Pointer trial. It's a groundbreaking study led nationally by Alzheimer's Association. And thank you so much, Claire, for joining us today and sharing this with us.
Oh, happy to, and thank you so much for including the U.S. Pointer study in today's presentation. For those that are not aware, the U.S. study to protect brain health through lifestyle intervention to reduce risk, otherwise known as U.S. Pointer, has been a clinical trial that the Alzheimer's Association has been running over the last 8+ years. And over 5 sites in the United States. And Sacramento was one of those 5 sites, working in partnership with UC Davis under the direction of our principal investigators, Dr. Rachel Whitmer and Dr. Sarah Farias, my colleague here on the committee. The point of Pointer, as we like to say, was really to understand whether or not lifestyle interventions can protect brain health and reduce risk of dementia in a large, diverse population of older adults in the United States. We recruited over 2,000, it was 2,111 participants, older adults from the ages of 60 to 79, who were at risk for developing cognitive impairment or dementia. And that risk varied from everything from familial, a family history to a sedentary lifestyle to cardiovascular risk factors. And participants were randomized into one of 2 lifestyle intervention groups that differed slightly in structure, intensity, and accountability. So we had a self-guided arm, which is exactly as you would imagine. It was, they met with an Alzheimer's Association navigator over the 2 years, 6 times. They had lessons where they would be given the information, but they were sort of encouraged to go out and chart their own course in making these lifestyle changes. The other potential group was our structured group, which, as you can imagine, was far more detailed. They also had an Alzheimer's Association navigator, but they were joined with an interventionist who was, in the case of California, a colleague at UC Davis, to really teach these lifestyle interventions in a more thoughtful or specific and structured way. They met weekly for the first 3 months, then every other week for the next 3 months, and then monthly for the 2 years that each participant was in the clinical trial. Cognitive function and other measures of the brain were assessed every 6 and 12-month marks for both groups, regardless. And the primary outcome for the clinical trial was change in cognition function over 2 years. Last Monday, at the Alzheimer's Association International Conference, the U.S. Pointer Study released their top-line results for the U.S. Pointer trial, and I am beyond thrilled to say that the trial was positive. Overall, both groups did very well in the intervention, and there is some really looking. This was top-line data. We finished this trial in May of 2025, so we had a very short window between May and last Monday to release these top-line findings. But what we found was that cognitive function improved over time for both groups. However, their structured intervention had a significantly greater benefit of cognitive function. What was really interesting, we worked really hard to recruit a diverse cohort, including both gender and ethnicity. 31% of our participants nationwide were ethnically diverse. And what was really great is that for the benefit was the same regardless of gender, age, or APOE4 genotype. So there was none of those other factors, which we know are risk factors. Women are more likely to develop Alzheimer's than men. Age is obviously a risk factor, as well as your APOE4 status. It did not have an impact on the results. And so what we saw, the group difference in cognitive function over time between the two groups from baseline to the 24-month visit really sort of equates to about 1 to 2 years of cognitive benefit for those that participated in the structured group. What the participants learned were how to make those lifestyle changes around diet, exercise, cognitive and social engagement, including brain activities, brain games, as well as those other cardiovascular risk factors, diabetes, high blood pressure, cholesterol, all of those sorts of things. So overall, the study was a positive outcome. Like we said, both groups did see a positive outcome, but we did see that statistically significant benefit in the structured intervention. And this study was based off of the Finnish finger study that was done several years ago, a little bit different in design, really based on our population here in the United States. So like I said, these are our top line results. We know there will be more results coming out as we get to really deep dive into this data. But it was exciting to see that positive outcome, and to know that this is really just the beginning of how we then think about exploring lifestyle and risk factors when it comes to reducing risk for Alzheimer's and dementia. In, I think, November, we will see some of the top line results of 4 NIA-funded ancillary studies that are looking at neurovascular, imaging, sleep, and the microbiome, gut health. So we'll be able to see what many of our participants participated in, at least one, if not more, of those ancillary studies to get some of that additional data. So I'll turn it back to you, Wynn.
Great. Thank you so much, Claire, for sharing such an important update for the U.S. Pointer trial. And this research reinforces interventions that can truly make a difference in maintaining brain health and give us an actionable insights to consider as we continue the amazing work we do in California.
All right, my turn. I'd like to introduce Tina Fung, Chief Alzheimer's Disease Section, California Department of Health.
Good afternoon, everyone. Would you like me to proceed, or are there other additional committee updates?
You can go ahead and proceed, Tina.
Okay. Hi everyone. Good afternoon. I'm Tina Fung. I'm the program manager for the Alzheimer's disease program at CDPH. We will be starting with our updates on our current work. And joining me today are my colleagues Lisa Gonzalez, who is our communication and prevention lead, and Cindy Foltz, and she's our clinical and caregiving lead. They will be available during my updates to provide further information if needed. So I'm going to start with our prevention focus area. Next slide, please. So in 2024, ADP launched the Take on Alzheimer's media campaign, which ran for about a half year. And because ADP's Take on Alzheimer's media campaign has ended, the campaign website has been deactivated. However, visitors to the website are now referred to ADP's webpage within the CDPH website for the same resources on Alzheimer's disease and related dementias. And we will be able to provide you the link to our ADP webpage as well. Next slide, please. And in addition, we have the California Healthy Brain Initiative. So that funded 13 local health jurisdictions to promote brain health, address Alzheimer's disease and related dementia, and support people living with ADRD, as well as support for their caregivers. And that has sunset on June 30th. So we have completed an evaluation report of the pilot cohort, and that includes 6 counties that worked on this initiative from 2020 to 2022. This report will be posted on our CDPH webpage very soon once we complete some last minute image requirements for ADA compliance. And we'll be focusing on evaluating the newer cohort of 7 sometime in the near future. Next slide, please. For our federal grants, ADP is in its 2nd year of the block grant. We are finishing up data analysis for the community needs assessment, and we're preparing a communities of practice for the 2nd year. This is where we will host regular meetings with potential partners to share some best practices in ADRD work in the rural communities, which includes tribal communities. And for our BOLD grant, we are waiting to hear back from the CDC about our continuation plan for year 3, which starts at the end of September, and also about our notice of award. The focus of the BOLD grant will remain in raising awareness of ADRD and supporting our HBI partners whose funding had just ended. And next slide, please. So our next focus area is clinical and caregiving. For our California Alzheimer's disease centers, we don't have any additional updates from the May updates, but our CADCs are still working on revising their assessment of cognitive complaints toolkit for Alzheimer's disease, and they are planning to, once they finish updating, they plan to adopt it and implement it at local clinics. Next slide, please. So for Dementia Care California, Dr. Anna Chodos and her team at UCSF have been working on this Dementia Care California website, and that will provide helpful information and tools for dementia screening and detection, diagnostic evaluation, and clinical care. The website has officially launched earlier this month, so we're really excited to share that news with you. And in the meantime, UCSF, their team, in collaboration with CDPH, is in the works of promoting the website. Next slide, please. We're also excited to share some more information about our caregiver training program. We have 2 contracts, one with UC Irvine, led by Dr. Stephen Tam, and the other is with UCSF in Fresno, led by Dr. Gavano. And both of them, for UC Irvine, their training has launched. For UCSF Fresno, their training modules, they have partnered with the Valley Caregivers Resources Center and focused on supporting caregivers in underserved and rural Northern California communities. So their training will be hosted on the VCRC website for 5 years. They're working on some web-based surveys. And let's see. They're also working on disseminating and user feedback collection, which will be ongoing. So that's really exciting. And thank you so much, Cindy, for providing the links in the chat box. And then next slide, please. And so our last focus area is research and evaluation. And ADP is continuing to provide technical assistance to our 7 research grantees. Their grant will continue until 2028. And then next slide. So while surveillance is not one of the 3 focus areas of ADP, they are our partners in our sister branch, the Chronic Disease Surveillance and Research Branch. And they just rolled out the Alzheimer's Disease Registry. Next slide. So CNDR is California statewide population-based neurodegenerative disease surveillance system. In 2021, California enacted the Health and Safety Code, which requires CNDR to collect neurodegenerative disease information other than Parkinson's disease, which has already been established. So the Parkinson's disease data had been collected since 2018. And so now they've expanded with other neurodegenerative diseases. In 2023, CNDR started collecting data on multiple sclerosis. And then, so just in July of this year, health providers in California are required to submit information about Alzheimer's disease to CNDR. And they have done quite a bit of extensive outreach this summer to raise awareness of this new registry. And so if you have any questions, you can contact our CNDR partners. Here's the web page link and also their email address. Thank you, Ranjana, for the information. And then last slide is our Alzheimer's D shared inbox email address if you have any questions, but that is all the updates we have for CDPH. Hi, Barbara.
Hi, Tina. At the last meeting, I raised the issue when the registry came up about underdiagnosis and how that might play out in this registry. Have you talked about that internally, how you might ensure that whatever data is generated by the registry, there is an understanding that this is not likely to present the full picture of people living in California with a cognitive impairment?
Yes, I've brought it up to CNDR, and I'll put the email address of their section manager. She would be able to provide more information on that. And when I raised this issue with our health and statistics unit, they are happy to provide additional information, and they are aware, this specific registry, when using the data, it doesn't paint a comprehensive picture. It's kind of like a snapshot of the data that they do have. And so I think that they will have that disclaimer that whatever data comes from this registry, whoever analyzes it has to, disclose that there is some limitations to the data.
I think that will be really important. When do you anticipate that there will be, is it a year out from its July 1 when they'll have data that they could share?
Yeah, that is their plan, is about a year out.
Okay, then can I put a pin in this? So the meeting that's next August, I'd love to have them come and share their data, and we can have this conversation perhaps directly with them. I think that might be very helpful.
Yeah, of course. Yeah, they'll be happy to,
Thank you.
to present.
Great, thank you.
More questions from the group? All right, let's move on to our legislative update. I want to introduce Barbara McClinton, Public Policy Director with Los Angeles, and Andrew Mendoza, Director of State Affairs with Alzheimer's Association. We're going to start with Barbara.
Thank you, Carlos. Okay, we're going to be moving pretty quick here. I just very quickly want to talk about HR 1. Susan referenced this bill when she was giving some of her update too, but I want to draw attention in a very specific way, and that is what the impact of this bill is likely to be on caregivers, because I think that's something that this committee should be aware of, because there may be state action that we want to ask for as a result of it. So the changes, which would be effective as of January 1st, 2021, relate to work requirements for adults ages 19 to 64. And there are some exceptions to those work requirements, including if you are caring for someone who is medically fragile or disabled. And you have to certify that every 6 months. And we don't yet know what the system is going to look like here in California that is going to be collecting this data to do these redeterminations. So this is something that I want to put out there perhaps for consideration for the letter for the secretary, is that as California is building this system, they need to do it in such a way that people who are caring for someone with a cognitive impairment, like, let's just try to make this as easy for them as possible, is what I'm trying to get at there. Because I think, unfortunately, what's likely to happen is that, especially if you're caring for someone who might be in the earlier stages of the disease, you might not think of them as disabled, or they might not be medically fragile. And so you might not think that you're eligible. I mean, I'm afraid people are going to self-select out and or just fall through the cracks when they have to do this redetermination every 6 months with everything caregivers have on their plate. And this is just a lot to expect of them. And then the result of it would be that that caregiver, if they're on Medicaid to get their health insurance, would lose it. Issue number 2 is Covered California. So if we have caregivers who may not qualify for Medicaid, Medi-Cal in California, who may be getting their coverage through Covered California, actually starting this fall, there's a loss of some of the enhanced premium credits. And so we do expect people's premiums to go up. And so it is certainly possible that, again, we all know families already spend a lot of their income to provide care for their loved one with cognitive impairment, a lot of out-of-pocket costs. So if they've got an increase in premium for their own health insurance, I just fear, that it may be likely that they say, you know what, I can't keep this health insurance coverage, and they drop it. And so once again, caregivers all too often put their own health very secondarily and experience the effects of that. And I'm concerned that these changes that happened at the federal level are only going to make that situation worse. So I really think we need to be watching that very carefully. Next slide. And then just a couple of bills that are still moving. The first one is a legislation that my organization, Alzheimer's Los Angeles, has sponsored, and this is trying to ensure that family-friend caregivers have access to their loved one or the person they're caring for during the duration of their time in the hospital. We did meet with Department of Public Health a couple of days ago. They have some concerns about the legislation. We've sent some language back. We're hoping that it addresses their concern. And the Department of Finance has also said that they're opposed to the bill. And we have I just learned this too a couple days ago. We have no details on the why. We've made a request to find out that information as well. So we are very close to the finish line with this legislation, out of the committees on the Senate side, waiting for a vote on the Senate side, on the Senate floor. But we have had some issues again from these two entities within state government pop up. And so we are going to be very diligently working through those and hoping that that doesn't get in the way of passage of the legislation. And then the other bill that's still moving is a bill that did pass last time that the governor had vetoed, related to expanding who would be eligible for paid family leave to include someone who is the designated person caring for someone, just responding to the reality of people's lives today, a lot of chosen family that are providing care. And so again, we are strongly at Alzheimer's Los Angeles, we're strongly supportive of this legislation and very much hoping that we see it pass this time. The bill is some of the issues that may have led to the governor's veto last time, I think, have been addressed. And so if we can make it through, we're optimistic that this time he will sign the bill. And that, I don't know if I have, and just a couple more that are both still moving. Again, we've talked certainly back in our previous meetings about emergency response and being able to do a better job for our older adults and people with disabilities, given the increasing likelihood of natural disasters happening across the state. And so I am happy to report both of these are still moving forward as well, which is really great and would be very helpful to support local planning efforts. And Susan already mentioned this one. We're really happy that the additional funding for the long-term care ombudsman program was indeed included in the budget. So important for our folks who are really vulnerable and really at risk in the care facilities in which they reside. I think that's it. All right. Thank you.
Works for me. The PowerPoint is thank you. I'm Andrew Mendoza, the Director of State Affairs for the Alzheimer's Association. We can move to the next slide.
Can we have you speak louder, please?
Yeah. Are you able to hear me at this volume?
Still kind of quiet.
How about at this volume?
Better.
Looks like he's muted.
Yeah, that's because of the room, because they've got challenges with them all being together in one room.
Can you hear me?
Yeah, I almost wonder if you should move to Wynn's seat. Sorry, musical chairs, but we do seem to be able to hear her better.
Yeah. We won't fight.
Or Claire over there in the.
It's okay. This is next to the candy bar.
Place to be, please eat it so I don't.
Say that out loud.
Can everyone hear me better now?
Much better. Thank you.
This is our sponsored bill. It's SB 412 by Senator Lamone, and it is adding a requirement on home care organizations to provide their home care aides with dementia-specific training to improve their care and involve individuals with their activities of daily living. It's worth noting that California has both affiliated and unaffiliated aides. The affiliated aides are working within a home care organization and they're subjected to the 5-hour training requirement, while unaffiliated aides do not have that same requirement. The unaffiliated aides may or may not be on the registry maintained by the Department of Social Services, which only indicates that they've passed a California Department of Justice background check. But some consumers may infer that they have received training based off of their advertisements listing them as a registered home care aide. This bill is on the Assembly floor currently. It passed out of Policy Committee and Fiscal Committee in both the first and secondary house. It does have to return to the Senate for a concurrence vote on amendments delaying implementation by 1 year, which were taken in the Assembly Human Services Committee. Move to the next slide. This bill is SB 470 by Senator Laird with the Bagley-Keene Act. So this bill enables state boards and commissions to meet using conferencing technology under certain provisions. It does extend these requirements to advisory boards, advisory commissions, advisory committees, and similar multi-member advisory boards. So since the last time we talked about this at the last meeting, it has been amended to extend the sunset on this policy until 2030. These provisions were originally placed into the code during the COVID pandemic. And the original bill had sought out to remove the sunsets altogether. But that is the policymaking process. And then we, along with other aging and disability groups, support this bill because of its ability to enable caregivers and people living with disabilities the opportunity to participate in decision-making that affects their lives. It also is supported by the Little Hoover Commission, who found that this policy saves the state money and increases participation more broadly. It is opposed, however, by the ACLU, the newspaper publishers, the Chamber of Commerce, and the Howard Jarvis Taxpayers Association, among other groups that have voiced transparency and accountability related concerns. During the committee hearing, the opposition did provide that they do support these abilities for the public to be able to participate remotely, but not for the appointed individuals. It is now in the Assembly Appropriations Committee. It has received some no votes from Republican members, and some moderate Democrats have registered as no vote recorded due to their strong positions on the Brown Act during the COVID pandemic. While this isn't exactly affecting that policy as it affects the Bagley-Keene Act, there are similar coalitions at play, so they've maintained their position. Move to the next slide. SB 530 by Senator Richardson. This bill extends time and distance access standards for Medi-Cal managed care plans, which are used to judge whether a plan has an adequate and accessible network of healthcare providers. These standards establish a minimum wait time for appointments and a maximum time or distance from a beneficiary's place of residence within which specified types of providers must be available. They did take amendments that removed an expansion of the definition of specialists. Neurologists, however, were in the existing definition. So when they took that amendment, it did not remove that. So these provisions will be applicable for that specialist. They did also push back the sunset to 2029 instead of making these provisions permanent. And that helped remove opposition from local health plans. It now has no opposition at all. Before the opposition was removed, the Republican caucus largely voted no in the Senate. In the Assembly Health Committee, it did receive unanimous votes, and it is now in the Assembly Appropriations Committee. Move to the next slide. AB 116 is the Health Omnibus Trailer Bill. It's authored by the Committee on Budget. It includes many different provisions. We were supportive of one provision from the Department of Healthcare Services to decouple the training requirement and the reporting requirement currently supported through the Dementia Care Aware program from the Medi-Cal billing code associated with cognitive health assessments. However, it does a lot more. It also reinstates the Medi-Cal asset test limit at $130,000 for individuals and $65,000 for each additional household member. This is much better than the original proposal of $2,000 for individuals and $3,000 for couples. There's a few different exemptions here, like your primary residence, one car, the holdings within a 401k, but not once you start drawing that down. So this does provide some flexibility for people to maintain the money in their accounts to pay their bills and make their rent. Another provision within here does impose a freeze on the Medi-Cal enrollment for undocumented individuals, and it instates a $30 premium for this population. It does also eliminate the skilled nursing facility workforce and quality incentive program, which provides incentives for facilities to improve outcomes and invest in workforce. It suspends the requirement for skilled nursing facilities to have an alternate source of power for no fewer than 96 hours during a power outage until a reimbursement rate add-on to support the cost of this requirement is approved by the legislature. This requirement was originally implemented pursuant to AB 2511 by Assemblymember Irwin and was chaptered in 2022. It also expands the definition of contractors subject to sanctions to include providers of the home and community-based alternatives waiver and programs for all-inclusive care for the elderly. This bill was chaptered on June 30th, so it is in effect. Some of the provisions that I mentioned had some kind of stopgap and ability for people to get onto Medi-Cal before the freeze had happened. And then the next slide is my last bill. So this is SB 331 by Senator Menjivar. This bill includes chronic alcoholism in the definition of gravely disabled. It also defines mental health disorder as a condition outlined in the Diagnostic and Statistical Manual of Mental Disorders, or what's known as the DSM. And lastly, it permits an original petitioner to be assigned ongoing rights by the care courts. This has become a 2-year bill. We are going to be participating in discussions during the interim recess. Primarily, we're concerned with using the DSM to define a mental health disorder because it includes conditions like Alzheimer's and caffeine dependence, among other serious mental health issues. And there's similar concerns shared by mental health groups and service providers, and they believe that the definition is too broad and could overload the system. The author provided a response to that commentary saying that first responders would have to interpret behaviors and not diagnoses, and that they are trying to provide a definition where there is currently none. However, we do think that there's more work to be done on this bill. So we're happy that it's a 2-year bill and happy to keep conversations going during the recess. It will have an expedited timeline to pass once the legislature reconvenes from that recess. But that's my last slide.
Thank you, Barbara and Andrew. I'll open it up to the committee for questions and answers. Anybody have any questions or concerns? All right, no hands are raised. We're going to move it on to public.
Get on to Sarah real quick. Yeah, I have we realized that we wanted to update the committee on a recent award or grant project that we are engaged in, so that because it's something of interest to you all. I recall last year or a year and a half ago or so, you had a few in-depth discussions on the issue of people who have developmental disabilities, intellectual and developmental disabilities, who are aging and living longer, which is great, but who also at the same time, particularly those with Down syndrome, are acquiring higher rates of Alzheimer's. We are participating in, you've been told in the past about our Bridging Aging and Disability Network initiative, where we are working with the Department of Developmental Services and a state action team, including some of our partners here, as well as Area Agency on Aging partners and Developmental Disability Network partners, to better develop approaches that streamline access to services across the aging and DD systems, and as a way to prepare the caregivers of people with developmental disabilities as both they age and as their son or daughter ages as well. So separately, we have been participating in a peer learning collaborative with that is supported by the Administration for Community Living, and is also led at the federal level by the National Council on Aging. And we did a lot of work last year in the area of the direct care workforce. This year, they invited California to apply for a more in-depth approach through a state action lab, where they would enable us to use $250,000 worth of consultant services for something related to a direct care workforce need. What we did is we, something that we have learned that is needed is training of people in both the Aging Network and in the IDD network of this issue of how you care for people with IDD as they age, what the resources are, and what they can do. So we were really pleased that ACL and the National Council on Aging really, really liked this proposal and this approach. And they're supporting us through consultation with a consultant group led by the Center for Healthcare Strategies to develop curriculum and for a training that we will eventually house online that can be for our networks, to both paid caregivers and unpaid family caregivers, to provide them with training and resources as they care for their loved ones with IDD as they age. So Tanya, you and your team have been leading this. Do you want to add anything on?
There's not too much more to add, other than we just have a great network ready to hit the ground running with this grant opportunity. And with the federal partnership, we're just really excited to have this, just magnifying across the state as best we can right now. With the limited resources available in the state, these partnerships are just invaluable. So yeah, it's a very exciting time from that perspective.
So that's what we wanted to say, unless there's any questions from the committee.
Sarah, let me ask, is there any attempt to educate primary care providers about the same topic?
That's a wonderful question and suggestion. I think what
Barry, you just got muted. I think the meeting room itself there you go.
Okay, can you hear me now?
Now, yes.
That's a really wonderful suggestion and question. And I think what we could do is, I'm imagining, this is an angle that we can raise with our partners. I don't think anything would preclude us from making the trainings available to the primary care network. Because the important thing is for them to understand, what changes occur in people with IDD as they age and what resources are available. So that's certainly something that we can, think through, and we can keep you updated. If you're interested in being more involved in it, of course, we would welcome that as well. So we're happy to, our lead on that is Teresa Weaver, and we can make sure that she, connects with you or, keeps you posted.
That'd be great. You know, our experience in clinic is that we have a referral clinic for adults with Down syndrome, and they come to us with a primary care provider that's perhaps been involved for many years in their care, but that provider is just not comfortable with understanding, evaluating, and really diagnosing cognitive impairment in these older folks. And what happens is there's a lot of confusion. It's very likely that a lot of tests are done that are not necessary. And it's also true that they're not able to provide the family with the kind of information they need to care properly for their loved ones. So I think a focus on primary care providers would be really, really helpful.
That is a wonderful idea. And I think what we should do, Dr. Mobley, is have Teresa Weaver connect with you, and we can think about maybe there's, maybe there's also a way to work with Anna Chodos and UCSF and Dementia Care Aware in these instances. If you know these, if there's a handful of providers, maybe we can get a sense from them on what would be helpful. So Tanya, let's remember to connect with Teresa on this. I think that would be really great.
Yeah.
Thanks,
absolutely.
Sarah.
To add to that too, we do have a partnering grant, which is the Bridging and Disability Network grant. With that, we're working with the Department of Developmental Services, and we have a state alliance team. So all that being said, being able to link these resources with primary care physicians as well as community health workers is definitely a priority for us. The SAL grant that Sarah just mentioned did have to be focused on caregivers very directly, but with this sister grant, that's also a federal partner, we are looking to expand these resources to these audiences that you just described, Dr. Mobley. Absolutely.
Great, thank you.
Sir, can I just, I think it's also worth noting we have to think about primary care beyond the existing validated diagnostic tools, because they won't necessarily be helpful with the IDD or Downs population. They're not designed for people who have those developmental disabilities. And I don't know that they will be as useful as the general aging population. So I think when it comes to this work, it's very complicated to identify these changes. And I think it's the same with caregivers, right? What caregivers need are not the same thing as our caregivers that we're used to dealing with. Have been caregivers their whole lives. So I think just keep that in mind too, that the existing screening tools might not be what's useful for primary care for this population.
That's a really great point, and something that I think we should remember as a need, that if there's ever opportunity to pursue funding for something like that, of how you assess people with cognitive impairments who are IDD. So thank you, really helpful.
Move forward to public comments if no one has any other questions.
Anybody have any more questions? If not, we'll move on to public comment.
Have a hand raised.
We have a public comment from Steve McAnally. So Steve, I'm going to unmute you. Are you? Oh, I'm sorry. Maybe. Jackie, do you want to go over this slide before I have Steve?
Yeah, that makes sense. Can you move forward with the spotlighting of me, Kelly? To go with Rex. Perfect. Right. Hi, everybody. We are going to transition to the second public comment period of this meeting. For those of you in person joining us, please just raise your hand and let the designated staff member on site know that you want to make a public comment. If you are joining us remotely via Zoom and would like to make a comment, please use the raise your hand feature of the Zoom platform and your line will be unmuted. If following this meeting or in future events you would like to provide us a written comment, we are more than happy to take that comment through our Engage inbox, which is engage@aging.ca.gov. And a friendly reminder, as we transition into our public comment period, we have it set up so each public commenter will have 2 minutes to share their comment. So yes, I do see Steve McNally, your hand is raised. I'm going to unmute your line. It looks like it's unmuted. I think you need to also unmute on your side.
Can you hear me okay?
Yes. Hi, Steve.
Yeah, I'm familiar with the process, so I unmuted when given the opportunity. Hi, my name's Steve McNally. I'm a family member with a son with schizophrenia, and it's my first time here. I'm a big fan of the Council on Aging and the Commission on Aging. I wanted to make you aware of something that's going on in Orange County. Orange County has a pivot project funded with BHSA money that's trying to find the intersection of mental health and Alzheimer's or dementia and housing. So when you were talking about the intellectual disability community and Alzheimer's, there is something else that's connected, and that's schizophrenia and autism. One has, I'm not a clinician, but I think one has too much dopamine, one has too little. And as people age, they are starting to get a diagnosis of schizophrenia later on, and they're left out with the silos of who wants to be primary and who wants to be secondary. And consequently, nobody wants to be primary, so it sort of goes challenged. So I just want to raise that to you and also see if in what you were talking about down the road, if there might be some opportunity for the Orange County people, since they have money in this process, to tag along with anything you're doing, if it has any interest to you. And then lastly, every board in California, every county in California has a local board that has welfare and institution code responsibility. It makes it a little bit different than most county boards and commissions. It's completely all citizens plus one supervisor. And if it was to go up the chain, it would go up to the California Behavioral Planning Council, which is 40 people across the state, 33 citizens, 7 state agencies, and then the BHS-OAC, the old MHS-OAC, Council of Behavioral Health, would be the lead agency on that side. So I just want to raise it for your consideration. And I didn't see a timer, but I'm pretty much done. Thank you.
Thank you, Steve. You are right at that 2 minutes. Appreciate it and appreciate your comments on this topic and your participation today. Other public comments, I'm going to ask my colleagues who are in the office today participating in this meeting if there are any comments in the room, and then I will transition to those who might be attending remotely. Not hearing that there's any in-person comments, let me go back to our virtual participant list and see if there are additional comments from those attending via Zoom. At this time, I'm not seeing any additional hands raised in Zoom. So I will, looks like one more comment has come in. Lucy Nicole, let me unmute your line and then unmute on your side as well.
Hi, can you hear me?
Yes. Hi, Lucy. You have 2 minutes to share your comment.
I'll make it short and sweet. First off, thank you for extending the invitation for people on the outside to join and listen in. My phone kept having issues going in and out, and I want to know, are the transcripts or the slideshows, are those available after this? Or is there any way I can get, because I missed some of the, I'm taking notes as fast as I can, and I missed a couple of things, and I want to know if are these going to be available online, or can I get them emailed to me?
Yes, we can. All meeting materials from
Yes.
this committee are posted online,
Mhm.
including the agenda, the PowerPoint, as well as the recording. So I'll have my colleague place in the chat for everybody the link to that public-facing website where materials following the session can be gathered. It takes us a little bit of time to gather all the materials, but meeting materials from this meeting as well as past meetings are available there.
Great. Thank you so much. A lot of good information you guys covered. Appreciate that.
Thank you. And it looks like it is in the chat.
Okay. Thank you. Or chat.
Any additional comments in person or via Zoom? Again, not seeing any additional hands raised on my side. I think we can transition away from public comment. Again, you always have the option to provide us written comments following this meeting using our email, engage@aging.ca.gov. I appreciate everyone's participation today.
Our recommendations for the secretary. As we think through the final recommendations, we encourage us to stay grounded in these outcomes and how they connect to the broader priorities. What stood out to you as the most impactful idea today? I know I noted a few things here. Dr. Mobley?
Yeah, I wanted to do maybe something a little unusual. I really want to stress to people how incredibly important the pointer study is, the U.S. pointer study. Sarah, I think you talked about that. It's really, it's really an important step forward in my view, because, and thanks to the Alzheimer's Association and Laura Baker and her team, it really tells us in a very clear way what works to help people hold on to their ability to remember and interact and cognitively function. I think, Sarah, you correct me, but I think in fact the progress people made in terms of their cognitive function actually significantly exceeded the natural history of those cognitive functions as revealed in other studies. And so just think about it, those lifestyle interventions are providing value that actually is more significant than the antibodies are for these folks with Alzheimer's disease. So I really want to say that I think they should be congratulated as a group of people. We should take note of the fact that their study protocol included the 4 elements that were mentioned, but also meeting with other team members. There were 24 meetings with team members for the structured group and 6 for the unstructured group. You wonder whether it was those team meetings that really stimulated their cognitive function. And then I guess a part of this is I really would like it for this committee to request that this information be widely known to the general populace, because here are things that one can do today, at least at the level of regular medical checkups, cognitive engagement, and community interactions. Those are all things that one could do today. And I really believe then that getting the message out that there is something one can do for people to hold on to their ability to remember and function right now. I was at the meeting, I heard the presentation, 2 people got up and spoke. One woman in particular got up and spoke and said that she was really just feeling not very good. She felt like kind of a lost person. She wasn't her best self. And her engagement in this program completely changed her life. She was transformed to be a much more active person, a much happier person, a much more engaged person. So I really would like us to really honor the U.S. Pointer Study and the work that the Alzheimer's Association put into it. I think it's a very important step forward, and I'm just hoping we'll have more studies like that to help confirm the benefit and help to show us what are the key elements of that.
Thank you, Dr. Mobley. Dr. Farias?
Yeah, I just wanted to respond to that and to apologize. I thought I was giving a presentation on Pointer at 12:10. I couldn't be here until that time.
Oh,
And
was it somebody else, Sarah? Maybe it was Claire.
Yeah, so Claire stepped in
Okay.
and gave an off the cuff presentation. So thank you, Claire. And I apologize. But I'm happy to respond. And if we do have time, I'm happy to bring up the slides just to show the change over time, if that's okay.
I mean, it would help. I think it would help people see that.
Okay, let me see if I can share my screen here. It looks like I need to be allowed to share.
Rosie, share.
Did that come through? Did you receive a request?
Not yet. Oh, now I can. Okay. So let me just pull up the slides and I'll just go directly to the results slide here. As you heard from Claire, and I didn't get the she was just finishing when I logged on, so I'm not sure all that she described, but in the Pointer trial, we basically had two treatment arms. So one was what we called the self-guided, and one was the structured arm. So the self-guided was basically a group that got education and met a total of 6 times, so 3 times a year. It was a 2-year intervention. Whereas the structured group met, I believe it was 36 times over the course of 2 years, starting weekly and then gradually going to monthly, but had a very prescribed regimen. And I'll just pull this up. This is what we call the Pointer prescription. So this was basically the primary intervention. So people were exercising in a very specific way. The goal was 4 weeks of or 4 days a week of aerobic exercise, in addition to 2 days a week of resistance and stretch and balance training as well. They also follow the MIND diet. They used Brain HQ, which is a computerized cognitive training program. And then they got health coaching, primarily to make sure that things like their blood pressure and glucose and things like that were under well control. So that was in a nutshell the intervention that the structured group got. And like I said, the self-guided group got information about that education, but they could kind of pick and choose how they wanted to implement that that information. And so in this graph here, it shows basically the tracking the global cognitive composite, which was the primary outcome. So this was based on cognitive testing across measures that look at memory, executive function, and processing speed. And the dark purple line represents the structured group, and the light purple, the self-guided group. And so you can see at time 1, which is 0, so that's baseline before they got the intervention. Then at 6 months, 12 months, 18, and 24 months. And so hopefully you can appreciate that as time went by, those lines diverged, meaning that the structured group showed more cognitive benefit than the self-guided group that didn't have all that support and the very specific behavioral goals in terms of the health, the physical activity, diet, cognitive training, and the health coaching. So we do believe that, it's statistically significant. And then, there were analyses to make sure that this effect was similar across different segments of our sample. So the benefits did not differ significantly across sex, age, ApoE4 genotype, which is a risk for a genetic risk for Alzheimer's disease, nor heart health at the beginning of the study. So it did seem to be beneficial for a wide variety of people in our sample. And really what this translates to on a kind of real world level is that the interventions seem to provide a benefit such that it slows cognitive aging by 1 to 2 years. So really, we feel like that's a pretty significant gain. And I will also, to mention, this study was funded by the Alzheimer's Association, but the NIH has funded several ancillary studies as well, looking at the impact of the intervention on imaging, including clearance of amyloid, the health of blood vessels, the impact on the gut and the gut-brain connection, and then the impact on sleep as well. And so those results will be forthcoming quite soon, is the plan. And then for those of you who want to look up the actual article and get more details, this is a QR code that you can pull up that article directly. I'm happy to take any other questions too.
Thanks, sir, for bringing that forward. Again, I think when you think of the benefits that they're showing there, those benefits are actually greater than the benefits that are being demonstrated using infusions of monoclonal antibodies. So the good news here is people can right now, in their normal lives, do things that really make a difference in their aging parameters.
Yes, I agree. Now, not everybody in the trial has amyloid, so I think it's again a benefit to a wide variety of people. And I think to your point too about then translating this intervention to the wider public and putting out this information, and also trying to think about how this trial can be implemented in the community. And the Alzheimer's Association remains very, very committed and has committed, I think it's $15 million. Claire, if I got that wrong, you can correct me, but to implement, to figure out how to implement and how to bring these results into the community. And I think that there is an opportunity for California, for organizations that are part of our meeting today to think about how we can do that, how we can implement programs like this to have a real impact on people that live in California and worldwide, really. But yeah.
We had a question from Barbara and Dr. Kosky.
So mine were comments about the letter to the secretary, which we started that discussion, but I can hold my comment if Dr. Kazi wants to speak to what Sarah just
Sure,
this
yeah.
topic.
I just want to echo the congratulations for doing this study so successfully, and of course how useful it is. One just more out of curiosity, but I think another practical, maybe post-study analysis that would be interesting if you have the resources to do so, is to look at the enrollees and the specific communities they were in, and the amount of air pollution or environmental aspects of their respective communities. And that would be one other factor that's a modifiable factor that we can then allude to in terms of the social settings people are in, for those that benefited greatly from the interventions and those that did not nearly as much. So just want to throw that out there. And again, Just wonderful slides, and thanks for the presentation.
I wanted to interject as a family caregiver caring for my dad. I've taken pieces of this study and adapted at home, and I feel that there is some positive outcomes applying some of these strategies into our daily activities, and I think I've prolonged my dad's life and reinforced some quality of life factors that encourages me as the caregiver to witness dad flourish. I think we need to highlight the Pointer study and make it available in a mainstream aspect that Californians can benefit from. The aging population needs to have as much support as possible. So we need to advance this outward in many ways.
Can I chime in here on that topic? And then so I would just want to make sure everybody's aware that organizations like mine, Alzheimer's Los Angeles, I know the Alzheimer's Association too, just so everybody knows, we've been doing community education about risk reduction and brain health for years. We have, and it says the same things that the Pointer study is proving are effective. So I don't want anybody to think that none of this messaging is getting out there, because it is, it has been, and it's been tailored for specific communities. So I know we have taken it for the African American community, the Latino community, the API community, so that we're using imagery that resonates with that community. We're using examples of things to do that resonates for specific communities. So what I think the Pointer study is phenomenal, and it just supports that the work we've been doing about risk reduction and brain health is absolutely on point, and that we all just need to keep doing it and doing more of it. So just like I said, I want to make sure people know that it is out there from a lot of different organizations. And then I don't know, Wynn, if you want me to speak to the letter to the secretary, or you want to see if others want to speak about this topic first and then come back to that.
Let's go see if anyone else has any further comments about this. I guess I'll add a few things. Yeah, I think what's different here, as you had mentioned, Sarah, is that this is a structured way of doing it. And I don't think we have done enough to intentionally do that. We have a lot of recommendations. I'm a physician, so I would say do this, X, Y, and Z. But I think if we make an effort to have, I don't know, maybe call them wellness coaches or whatever, within a health system or the community itself, maybe there's some clubs for pointers. I don't know what do you want to call it. For those who are interested, can have such coaching, more, not necessarily one-on-one, but I think it would be more impactful than the usual recommendations that we've been doing for decades and decades. Just wanted to highlight that part, that it is a structured session that has been more beneficial. Sarah, go ahead.
Yeah, and if I can just interject there, we in the trial, we didn't have a traditional control group that got nothing, because we felt strongly that that wasn't exactly ethical, because like we're saying here, there is some evidence certainly that these things work. It's mostly been from observational studies. So having a randomized control trial that really tests this is very important. But even from the behavioral change literature, we know that just providing the education usually isn't enough for most people. And it really needs to be more than that. And so that's where you get into how can we implement this so that there is support, similar to what we did in the trial, because that did make a difference, obviously on the cognitive outcome. And I think in terms of the, behavioral uptake and just changing those behaviors, those social relationships, the accountability, all of that, having specific goals, measuring those goals, keeping track of them. Those are all things that we know for behavior change are really key.
Anyone else? Barbara has been patiently waiting.
I actually, so there's a couple things that we didn't necessarily talk about today, but I still want to put them out here for possible inclusion in the letter. Does anyone know what the status is of filling Kim McCoy-Wade's position within the governor's office?
No, I don't have any updates on it.
So I'm just a little concerned. I know that Governor Newsom's not going to be in office for that. I'm just a little concerned that maybe there won't be the folks actually filling that position in the time that remains in his administration. And I think that position is really important. So I'd love to see us include something that just says to the secretary, hey, we really think this position's important and we'd like to see it filled. The second is, we talked about, Andrew and I gave updates on legislation and some budget items. One of the items that wasn't funded was a relatively small funding augmentation for the Alzheimer's disease centers. And I mean, I think we're just, hearing across this meeting how important they are. And so I don't know what that exactly looks like in the letter to the secretary, but I know that there are centers in our area that were saying if that augmentation is not there, that they're going to close. And that would be such a loss to the community. And so, whatever can be done, I don't know what it is, if there's not money in the budget, but we can't afford to lose any of those centers. So we really want to see effort made to make sure that all of our Alzheimer's disease centers are able to continue to do their very important work. And then the third is related to that implementation of the HR1 work requirement system. I realize that's not a tomorrow thing for the state, but our state is huge. Creating a system like that is not going to be easy. And so I just want the secretary again to understand that as it's being created, family caregivers of people living with a cognitive impairment, we need to make sure that the system is designed in such a way that they're able to access it and don't end up losing their Medicaid when they shouldn't. That's it.
Barbara, anyone else?
Where do we need further input or engagement before finalizing recommendations?
Ask that again, real quick, Carlos.
Where do we need further input or engagement before finalizing recommendations?
Yeah, does the committee have any other input recommendations or engagement recommendations?
And then we would draft it, CDA.
Yeah, no draft.
Well, thank you for your thoughtful input and commitment to this work. Your voices are critical in shaping strategies that are both meaningful and actionable.
We'll go ahead and send these recommendations and items to the secretary. Final slide or?
Let me tell Lindsay to put up the slide.
Again. But thank you all for your thoughtful participation and insights today. It's been incredibly valuable to engage in such a collaborative space where systems of care are not just acknowledged, but actively explored. As we reflect on today's discussion, I want to especially lift the importance of continuing to center around the lived experience of individuals living with Alzheimer's and related conditions, along with their caregivers. Ensuring that our recommendations are inclusive, trauma-informed, and rooted in dignity and choice is essential. Looking ahead, I'm excited about the opportunities we would identify today to strengthen partnerships across aging and beyond. Whether we're talking about service coordination, workforce development or policy reform, it's clear that our collective work is not only necessary, but is also urgent. Our next meeting is November 6th, the same time, 10 to 2. I think we had agreed that this would be the recommended where people would come in if they can, but there will still be options for the hybrid for those who can't. I think that's it. It is 1:18. Thank you, everyone.
Thank you.
Thank you. Bye-bye.
Bye.